Good afternoon, everyone, and thank you so much for joining in. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, COVID-19 updates and cardiac manifestations of long COVID. Just a reminder that this educational series is generally sponsored by a partnership between the California Medical Association and the California Health and Human Services Agency. Next slide, please. Here are our speakers' disclosures. Next slide, please. Here's our agenda for today. Next slide, please. And just a reminder that we do provide CME for this series. You'll be sent a survey after the completion of the webinar where you can attest to your attendance. And after you complete that survey, we'll send out your certificates. Next slide, please. After a massive summer surge of COVID-19, with many Americans having had COVID-19 more than once, we're still grappling to understand the epidemiology, causes, and manifestations of long COVID. After an update on the current status of COVID-19 and other emerging infectious diseases, including monkeypox or MPX from Erica Pan, we'll be hosting Dr. Donald Grandis, a UCSF cardiologist, who will discuss the cardiac manifestations of long COVID. So let's dive right in today and begin with our friend and regular presenter, Dr. Erica Pan, our California State epidemiologist. Following Dr. Pan's presentation, I will introduce Dr. Grandis. Thanks, Erica, as always.
Great, thank you so much, Kim. Good morning, everyone, or I guess good afternoon. Yeah, why don't we just launch into it? Next slide. So I'll talk, as mentioned, a little bit about briefly updates on MPOX and a little bit about how COVID-19 is looking in California. And of course, the updated bivalent boosters, wanted to say a few words about that, and always putting a plug in for treatment. We have some hot topic news of the day that will be issued today about our state requirements, and then a little bit about other activities with long COVID before we turn it over to Dr. Grandis. Next slide. Next slide. So here is where we are as late last week as far as California MPOX cases. And basically, as you can see here, over 4,300 confirmed cases. But the good news is, as you can see in our epidemic curve here, that it does look like we have peaked and that things seem to be improving. The peak probably was in early August. And again, seeing some declines there. We did sadly just hear about our first death in a severely immunocompromised individual in LA County just in the last few days. And probably about 4% of cases have been hospitalized. Often that's for pain management or other things, and then again, sometimes with more disseminated disease or more serious disease, there are hospitalizations. It's impacting over 41 health jurisdictions. Next slide. And then just kind of looking at the cases by jurisdiction, you can see largely in our urban areas, not surprisingly, is where we're seeing the largest number of cases. And then also looking at vaccine recipients by jurisdiction, we've just recently posted this data as well, starting last week, and we'll update this weekly. You know, just a couple other brief words about this. We have received over 144,000 vials of the Jynneos vaccine in California, which is again for post-exposure prophylaxis for MPOX or enhanced post-exposure prophylaxis for people at high risk. And we've administered close to 140,000 doses. It's of course become more and more challenging to look at doses versus vials. And as we switched from subcutaneous administration, which was 1 dose per vial, to intradermal administration, which is 3 to 5 doses per vial, but we are closely tracking that as well. We have just ordered another tranche of vaccine in what the federal government is calling phase 4 that we should be getting later this week, and continue to work with our local jurisdictions to get those vaccines out. But lots of progress there, and I think we're getting closer to meeting demand. We've also encouraged people to go ahead and start doing second doses. I think when we were really scarce with vaccine, we said it was okay to delay those second doses, but now we think we do have enough supply either now or coming to start doing that. Next slide. And then I'll shift over to talk a little bit about what's going on with COVID-19 in California. Next slide. bottom line here is that thankfully things are definitely improving. So the blue line again is cases, the orange line is hospitalizations, although as we look at discharge data from those hospitalizations, probably about half of those in the last several months have been sort of incidental findings or with COVID as opposed to for COVID. And then also very encouraging, the red line here you're seeing is the deaths, and those have continued to decrease. There is always a reporting delay there, but again, the trend is definitely in the right direction. We're watching that closely to see when we might hit similar levels to a severe flu season. We're not there yet, but again, watching that closely and seeing things improve. Next slide. And then this is another way that the CDC is categorizing different counties across the state and the country. And you can see this wonderful trend we have seen. I want to remind people this is not just levels of transmission, which is how we used to look at COVID-19. So there's still relatively high levels of transmission, but this community level starts to take into account what is the hospital and healthcare impact. So as we've seen new admissions decrease and hospitalizations decrease, that is what really influences the movement into the lower community levels again. So you can see almost 3/4 of our state, actually as of last week, are in that low level, and we'll have another update on that on Thursday. So things, again, thankfully, especially in the hospitals, seem to be decreasing and improving. And next slide. And then big news, of course, recently is that bivalent boosters are here. So I wanted to highlight, there were some really excellent slides from the ACIP meeting, and Dr. Oliver did some great presentations along with others. And I'm just including a couple key slides here to drive home a few points, wanting to emphasize that we have now been using this mRNA vaccine platform for almost 2 years, and over 600 million doses in the United States alone have been given. So we have a lot of vaccine effectiveness studies as well as robust post-authorization safety data across multiple platforms. And we have a very robust vaccine safety data network right here in California. It's been really rare to have accumulated this much data in such a short period of time. So building upon that, the manufacturers did create these bivalent COVID-19 vaccines, and they have had human clinical data from over 1,700 individuals that looked at Beta and Omicron variants. And those were done both by NIH studies and the manufacturers as well. Over 1,400 individuals got the bivalent vaccine with Omicron component specifically. And while there are some very subtle differences in some of the spike protein sequences between the BA.1 subvariant of Omicron versus BA.4 and BA.5, we don't anticipate, and the CDC mentioned, there are no anticipated differences in safety or reactogenicity of these vaccines based on these very small differences in those spike protein sequences. And the overall composition of these vaccines as well, the total antigenic load, are the same as current booster doses. And then there were other animal studies that looked at, antibody studies in animals, and then there was some modeling data, which I'll talk about in the next slide. But I wanted to highlight some of this because there's been a lot of media chatter about, oh, there's not enough human data, this is all done in animals, and there is this number, which is understandably, these are small numbers, but this is actually what we do with the flu vaccine every year. So I think it's a good reminder for you and your patients that, we've had a lot of experience with this platform, and then we've changed which variant is in there and a subvariant, but it really is not fundamentally different. And so we have really excellent clinical human data. Next slide. And this is a little redundant, but just another nice summary slide that Dr. Oliver presented. Again, just pointing out again, and you could see that from those epidemic curves I just showed you in California, these vaccines have dramatically reduced COVID-19 hospitalizations and deaths. And as this virus has evolved, we do see waning immunity, right? Declines in our antibodies. And that happens both from prior infection and from prior vaccines. So inclusion of this second subvariant in the vaccine broadens our antibody response. And again, when they did do these studies, they saw higher antibody titers for Omicron variants and also for other SARS-CoV-2 variants. And it was non-inferior to what we call ancestral SARS-CoV-2 variants, so either beta or earlier variants as well. And then they did some modeling and showed those in the ACIP, and we're working on doing that for California, just to look at California specific analogous data as well, but trying to look at if you have administration and a broad uptake of booster doses early in the fall, that it could prevent over 100,000 hospitalizations in the country compared to a later rollout or a more limited rollout, and billions of dollars of direct medical costs nationally. So, and again, we're trying to look at how that looks in California, and we can share that in the future. So wanted to, again, the links in these slides are really good if you want to see the full presentations, but those are some key highlights. Next slide. And then this is just a vaccine timing guide that our team puts together that we think really helps clinicians and even patients, because it does get more and more confusing. We now have Novavax in the field as well, and just showing that now really the emphasis is get a bivalent booster, make sure it's at least 2 doses since your last vaccine dose, no matter how many doses you've had, basically, and starting to think about being up to date as when your last dose was. If you've had a recent infection or your patient has over 3 months or so, 3 to 6 months after that is probably when the appropriate time is to get a booster. So these are all really helpful guides. And this just shows you which manufacturer for which ages, and we have a pediatric version of this and some nice social media that's coming out as well to really promote boosters. So hope that you continue to promote those with your patients as well. Next slide. And then I just wanted to spend a couple minutes on treatment, again, especially addressing some of the chatter out there that we hear about, just, more recent studies. And in the supplemental slides, there's a lot of more details on these various studies that our team put together. But, treatment definitely works, and early treatment is really important. So it does reduce risk for hospitalization and death, both in people who are vaccinated and non-immune populations. Again, just showing a big risk reduction in hospitalizations and deaths, especially, the more, age or underlying medical conditions are a potential risk factor for those hospitalizations, the more important it is to get treatment. And then as far as rebound, again, a lot of anecdotal reports, a lot of concerns about rebound. So this is just a brief summary of some of the different data out there. About 5% of patients in a trial of 13,000, a study of 13,000 treated, had rebound at 30 days. And then even in untreated COVID-19 patients, in one study, almost over a quarter had symptomatic rebound and 12% had a viral load rebound. So it's actually potentially, if you looked at those side by side, which they're not equivalent data, but you might say that untreated COVID-19 patients have more rebound than treated. And then there's another post-hoc analysis of the original Paxlovid study population, and again, very low percentages of rebound seen in those in that post-hoc analysis. It is more common in people who are older or who have risk factors, but again, treatment in of itself is not necessarily something that's then leading to rebound. So wanted to make sure you have that data as well. Next slide. And then we're really excited that we have just launched up to $59 million for safety net clinics and health systems to expedite test to treat. And again, it's really important, as you all know, to get treatment early to be the most impactful. So there are grant amounts anywhere from $50,000 to $1 million for these different clinics. You can see the eligibility criteria here. Grant applications are due September 30th, and this is the website to get more information, but really looking again to help improve workflows and processes to decrease the amount of time between treatment once people test positive, especially if they are at high risk, and really wanting to reach our most impacted populations and with an equity lens. Next slide. And then just probably as we speak, we're posting some updates to our state public health officer orders. So we have looked and, the orders that we put into place, last winter, essentially, along with requiring vaccination in certain settings and boosters, there was testing of of unvaccinated workers. So that basically the bottom line of the changes that we're about to post today are that required testing of unvaccinated workers in these various settings that we have these health officer orders are being removed. We just, over this time now, we've seen a lot more immunity, both from vaccinations and infection. Vaccine coverage is high among workers in most of these high-risk settings. And again, the proportion of unvaccinated workers is low. So those screening testing requirements of unvaccinated are going to be removed in school staff, healthcare settings, and some other congregate settings. Healthcare workers are still required to receive their primary series and at least one booster. And if they've already received that, that meets the requirements. This does not talk about whether or not people have gotten the new bivalent booster or not. But what's going away is the screening testing requirement for those who have exemptions for various reasons. So we're issuing and posting this today, and then it will be effective starting Saturday, just knowing there are some weekly cadences that happen in a lot of these settings. And for more information, it'll get posted again this afternoon on our guidance website for COVID-19. Next slide. And then just shifting, because the theme of today is long COVID, I wanted to just share a couple things. One, we have very recently posted a lot of resources for people with post-COVID conditions or long COVID, including kind of links to where to get care for long COVID across the state, a little checklist of symptoms so that when you do make that appointment with a medical provider, you can really provide as much history as possible that really helps your clinician help assess, and other tools for recovery and rehab, support groups for post-COVID conditions, and a lot of other great resources. So check that out. Please feel free to let your patients know about those. And we're trying to work also on some flyers and more patient-friendly resources as well that are kind of one-pagers that you can post or give out. And then I wanted to just very quickly mention and highlight some of the different collaborations we have in the California Department of Public Health looking at the long-term impacts of COVID and long COVID. We have a collaboration that's actually a national study, and on our next slide we'll talk a little bit more about that, but we've been within California, UCSF and UCLA are key sites, so I'll talk more about that in the next slide. And then our Cal Connect, which is our, actually go back one briefly. Cal Connect has a survey so that local health departments can actually ask patients who have tested positive for COVID about their symptoms on an ongoing basis. We've been working with local health departments to see what their needs are to help assess in their jurisdictions. We had done a seroprevalence survey that also we've added questions to that to ask patients who have had COVID about their long-term symptoms. And then we're collaborating with a CDC study that also is a web-based survey. There's some variations of phone surveys, web-based surveys, email surveys to really, again, try to do, in some cases, convenience sampling, in some cases, more representative sampling to really try to understand the long-term impacts. And so we also had a case control survey, so we're following up on that as well to, for those cases to really, again, assess symptoms and other long-term things, and then just continue to try to update our communications around this. Next slide. And then, so the INSPIRE prospective cohort study is national multi-site. They've just actually completed enrollment of to reach the minimum size, and about 1,200 Californians have been enrolled. And there's this great CDC dashboard where you can look at the nationwide data and studies and look at different characteristics and symptoms and see over time. So this has been another great public health and academic collaboration, and you can look at that website to see more data about the study. Next slide. And then I'm really excited too to share with the launching of the Smarter Plan. When California did that earlier this spring, we were able to also work to get some funding to work really closely with UCSF on something we're calling the Collaborative for Pandemic Recovery and Readiness Research, or CPR3. And there's some, a few different priorities here that we're looking at. We want to prioritize and fund some pandemic recovery and readiness research focused on the indirect effects of the pandemic and generating evidence to inform policies to improve lives for Californians, and really importantly to continue to build an infrastructure between UC and the Department of Public Health to continue to sustain this kind of policy-focused research. We've done so much with modeling consortium with UC that's been really helpful to inform our policy decisions and really building on that infrastructure. So stay tuned, there will be more to come on that, but really exciting that we recently launched this and a great academic collaboration. Next slide. So in transition here, I couldn't find my actual photos for my family, but I have a very similar image in my head of my dad and my parents, who my dad had a cardiac rehab pillow just like this. And I'm so honored today to have the opportunity to share with all of you what an incredible doctor and physician and person our next speaker is. This time of year brings a couple important anniversaries for my family. My dad had his first aortic valve replacement in 2019 around this time, and then he recovered. He was doing great, and then last fall he unfortunately had a repeat replacement due to complex endocarditis. And Dr. Don Grandis has been my dad's cardiologist through all of this, and I cannot express enough, and again, I love being able to do this very publicly for you, Don, that Don is just an incredible clinician. He's caring, he's conscientious about his patients and their families. He shares his incredible depth of knowledge regarding evidence and data, extensive clinical experience, and probably most importantly, he works really hard to find out what the patient wants and needs, and then just so responsive to every little question and follow up on their concerns. So I think you've, Don, really helped guide us through deciding on the right surgeon in the very beginning and all the difficult twists and turns with the complex endocarditis a year and a half in the middle of a pandemic. And then I got to hear about the great work you do leading the UCSF Cardiac Rehab Center. So thrilled to say my dad has recovered from both surgeries. My mom says that Dr. Grant has saved his life, and our entire family is just so grateful for such an incredible clinician and clearly an incredible leader as well. So just really excited again to turn this over to the most dedicated, compassionate, knowledgeable, and kind cardiologist. So thank you. I'm just pleased and honored to do this panel with you, and I'll turn it over next. Thank you.
Oh. Thank you so much, Erica. I'm so chucked up, I don't know if I can give my talk now. Well, thank you so much for those kind words, and I'm really honored to be able to speak with all of you today about this really important topic. I'm going to talk to you about post-acute COVID sequelae, how it relates to cardiovascular disease, and this is something that we've been seeing more and more of, and so I'm really pleased to be able to present to you some data and some experiences we've had. May I have the first slide, please? When I think about the long COVID cardiovascular manifestations, I think I need to start with what the acute COVID infection might do from a cardiovascular standpoint. So I want to just take 1 minute and have you focus on the upper left-hand corner. There's, in the acute setting, there's a couple of different pathophysiologies I think we can attribute to some of the disorders caused by a COVID infection, and I'm going to stay away from the virology. I'll defer all that to Erica, but for me as a cardiologist, the thrombosis vasculitis picture is probably one of the biggest parts. And I think we're seeing more and more accumulating data about microthrombi and coagulation disorders, thromboemboli being a factor that we see for months after a COVID infection, and also what some people are calling a vasculopathy or endothelitis, where the endothelium has been injured by the actual direct effect of the COVID virus, causing vascular disorders. But at the same time, we're also seeing some evidence of inflammation with elevated IL-6 levels. And then what transitions after the initial infection is what you see in panel B, where we see multiple different cardiac manifestations of an infection with infarction, inflammatory myocarditis, Pott's disease, and then can lead to some more long-term sequelae as shown in panel C. I think the one thing I want to comment on quickly is if you look below panel B, there's this issue about possible mRNA vaccine-induced myocarditis. I want to just take a minute to mention that because I know that's a source of concern for some, but I want to remind everybody that the evidence so far is that the vaccine itself carries a very low incidence of myocarditis, somewhere in the order of 30 per million vaccines administered. And most of these people are relatively young, healthy males who almost universally recover completely. So I think there's been some misconceptions about the vaccine that it might actually cause cardiac disorders where it really is very rare. But most importantly, for those who are not vaccinated, who end up with a severe infection, the incidence and sequelae of myocarditis is much more common, much more serious, and much more likely to be dangerous. So I don't want people to be misled that the vaccine is a significant cause for cardiovascular manifestations of COVID. On the contrary, if the goal is to prevent myocarditis, the best solution is to get vaccinated to reduce your odds of getting an infection or hospitalization. And then in the bottom right corner, you see panel D. So what we're going to talk about mostly today is long COVID. And I thought the diagram illustrates fairly well the kind of problems we've been seeing where people sort of have a vacillating course. It varies tremendously between individuals. I wish I could tell you there's one typical prototype. I think there's not. Some people seem to have symptoms of a cardiovascular disease that lasts more than 90 days after their infection, but then seem to recover without doing anything. There's some who make a partial recovery, as shown in the red stipple line, and then there's some who seem like they recover fully, but then relapse months later. So that's really who we're focusing on today are those people. May I have the next slide, please? So one of the questions I think one can always ask themselves is when we're thinking of long COVID, obviously one of the main drivers of what's going to happen here are symptoms. That's going to be what brings somebody to your attention. And one of the questions I ask myself is, are these symptoms related to the COVID infection the person had 90 days ago? I think this study that was just recently published in Lancet from Netherlands was very interesting. They took a group of people in northern Netherlands who had been already involved in a public health study, and compared those who had COVID to those who did not have COVID, 4,000 people with COVID and 8,000 without, and they looked at their symptoms before, during, and for months after their initial infection. And if you focus your attention on the top two right graphs, what you'll see is that there was a large increase in symptoms of both difficulties with breathing, a typical cardiac symptom, or chest pain immediately after the infection. But then in both men and women, women are shown in the red line and men in the blue line, for months afterwards, the chest pain persisted. And they, in this study, did a very clever thing. They compared it to controls, people who did not have COVID or at least known COVID, and found that there was a statistically significant increase in people suffering with both troubles with breathing as well as chest pain for up to 250 days after their initial infection when compared to their controls. And then the next slide, please. And more worrisome, I think, is I showed you where the chest pain and difficulty with breathing are on the graph, so focus there if you can, is there was actually a significant proportion of those people in this population who their symptoms actually worsened over time. Now, the numbers weren't huge. Approximately 2% of people had worsening symptoms over time. But if you think about the number of people in California who have had a COVID infection, 2 to 3% is 200,000 to 300,000 people who are post-COVID, 3 months out, 90 days out, and are actually going to have worsened chest pain and difficulty breathing after infection. So this is going to be a significant problem for all of us, I think, as we go forward, because we're going to see a lot of people with these symptoms post-COVID. And again, the percentages are not huge, but they are statistically different than those who did not have COVID. So I do think it's real. And more importantly, there's a lot of people who their symptoms actually worsen with time. So next slide, please. So when I think about specifically, what are we talking about? Those are the symptoms that might draw people to your attention. What are people having medically that is a cardiac manifestation of COVID in the long COVID syndrome or in the PAC syndrome? And these percentages are not supposed to be 100%, but these are the types of abnormalities we're finding when we evaluate people post-COVID. About a third of the time, there's some type of arrhythmia. Most common one is atrial fibrillation, which you'll see in the graph above. And again, this is something that we're seeing more common than you normally would in, for age-matched controls. The myocarditis, myocardial dysfunction percentages have varied widely. And part of the reason for that is the ways that people look for that disorder post-COVID has varied tremendously, and the methodologies vary. I showed MRI of a heart to show you some different ways to look at it. Not that I would expect everybody to be doing these, but when we look at edema, which you can see fairly well using T2 weighting on MRI, people with a myocarditis picture post-COVID seem to have more edema than the controls. But there's also other techniques using gadolinium to look for late enhancement, which is a sign of myocarditis. But that gets a little confusing because we know that in the normal population, some people will have this perhaps due to a prior infection from other viruses or injury. So we're not really sure exactly how often myocardial dysfunction, myocarditis happens long-term, but those are the things we're seeing. POTS disease, which I'm going to talk about a little bit more detail in a minute. Some studies have suggested that there's up to 30% of patients post-COVID are having this disorder. The others have not suggested it's high, but it does seem to be fairly prevalent. And pericardial effusions, which are fairly common after a severe viral illness, but seem to be more common than we might normally see in the post-COVID world, seem to be increased in prevalence. And I was on service for 2 weeks in July when we had a surge. And I can just tell you personally, I've never done as many pericardial centeses in 2 weeks in my career as I did those 2 weeks when we had a surge. So it's real, we're seeing it. And the pericardial effusion shown on the CAT scan there is another phenomenon that we've seen. And then lastly, autonomic dysfunction, which I'm also going to talk a little bit about more in detail, has been evident. Now, some might argue that's more of a neurological manifestation, and I agree with that, but because of the overlap with some cardiac diseases, for example, autonomic dysfunction may show up as a bradyarrhythmia or sinus bradycardia or sinus tachycardia, it probably should be considered a cardiac manifestation. Next slide, please. So just how likely are these things to happen to an individual after a COVID infection? This is a study that I thought was informative. It came from the VA health system, so its applicability to the general population is not the same, but it looked at a large number of patients who contracted COVID. If they survived 30 days, they looked at the incidence of developing a cardiovascular disorder and compared it to their age-matched controls. And what you can see is going down the first column, in any kind of cerebrovascular disorder, dysrhythmia, ischemic heart disease, or heart failure, or even thrombotic events, and shown the next column down, the hazard ratio for developing all of these disorders was significantly increased compared to their age-matched controls in the VA population who did not have an infection. Now, there are some limitations to a study like this. We don't really know if the controls did not have an infection. It's also not generally a representative population, but I think the message is clear that there is an increased risk of developing many different cardiovascular abnormalities after at least 30 days after a COVID infection that they saw in this population. But I think the two most important findings to keep in mind are the sicker a person was initially is the more likely they are to develop an illness, and that makes intuitive sense. However, what was also interesting is even in the young, healthy subjects who had mild symptoms with their initial COVID infection, they still had an increased risk of developing this disorder. So unfortunately, the problem does not go away even in some of the healthiest individuals after their initial infection. Next slide, please. So let me help with understanding what POS disease is. So first of all, it's an abbreviation for what we call Postural Orthostatic Tachycardia Syndrome. And what it is an abnormality where when a patient goes or a person goes from lying to standing, there's an abnormal increase in heart rate. So normally in all of us, when we change our posture going from lying down to standing up, the heart rate will increase somewhat, maybe 10 beats per minute more. But in POS disease, the heart rate actually increases over 30 beats per minute within 10 minutes of standing, or the other definition would be if the heart rate goes over 120 without becoming hypotensive. And that's uncomfortable to the patient. It doesn't feel good to have your heart racing at 120 beats per minute standing still, just simply from going from lying to standing. It feels uncomfortable. And it needs to be distinguished from autonomic dysfunction. So if you see there's 3 different graphs here, the top row of graphs is what a patient's heart rate does when going from lying down to standing or tilt up. And the bottom is what their blood pressure does. So in autonomic dysfunction, what happens is the blood pressure drops unusually low, as shown in the bottom graph, after approximately only 100 seconds of being upright, but the heart rate actually does not really change much. So that tells us that the autonomic nervous system is not responding properly to the head-up tilt. In contrast, when you look at POTS disease on the far right, what happens is the patient goes from lying to standing, and the blood pressure actually is fine. It does not drop, but the heart rate, shown in the top graph, goes up unusually high. So it's a completely different disorder from the autonomic failure problem. And the one in the middle is the more typical thing that we've seen, which is called neuro-mediated syncope, where a person has increased vagal tone and passes out. But I think if you're not sure what's happening to your patients when they're going from lying to standing and don't feel well, a tilt table test is actually a very helpful test to distinguish it and understand exactly what the pathology is. Next slide, please. So how do we go about evaluating our patients? There's going to be these people that come to us with chest pain, shortness of breath, palpitations. What should we do? And I'm going to try to make this in a somewhat of a thoughtful, measured approach, meaning using our tests wisely. Everybody should get a good, thorough exam. And what I'm looking for particularly is the rhythm. I'm listening for a rub to see if there's evidence of pericarditis and looking carefully for signs of heart failure. But beyond that, 2 tests that I've been doing fairly routinely if I'm pretty concerned about a myocarditis is checking both the CRP, because that's usually elevated in either pericarditis or myocarditis, and the serum troponin. Now, that may not be valuable in all people, but the flip side is if they are abnormal months out from an infection, that does heighten my concern that there might be a myocarditis or pericarditis that needs to be pursued further. I think an EKG is also a very cost-effective test to do as a screening test, and that's pretty much where I stop my initial evaluation unless there's something that's particularly worrisome on the history, physical, or initial lab data. That said, an echocardiogram is always reasonable if there's concerns about heart failure, myocarditis. For those that are having palpitations, a heart rhythm monitor may be reassuring to rule out abnormalities such as atrial fibrillation, which we're seeing. Stress testing is probably not necessary in most people unless the chest pain sounds like it's from coronary artery disease, so I don't recommend it for most. And for those that I think there's a high suspicion of myocarditis, on cardiac MRI is probably the go-to test. There are people who will have evidence of myocarditis on MRI that will not show up on echocardiogram. So if the suspicion is high, then that might be the test to do. Tilt table test, as I mentioned, is a good test to help distinguish those who may have POTS disease or autonomic dysfunction, distinguish the two. And then lastly, test that we don't use often but might use is the 6-minute walk test, which actually has been shown to be valuable in the post-COVID world to make predictions about how well people will fare. And here at UCSF, we've been actually using the CPET, or cardiopulmonary exercise test, which is a specific test where oxygen consumption and CO2 production are actually measured. And this test we're finding to be valuable for those who have poor exercise tolerance. So not necessarily those who are having chest pain per se, or have an abnormal heart rhythm per se, but those who just have poor exercise capacity, we're finding that to be very helpful to distinguish, is this coming from a cardiac abnormality, a pulmonary abnormality, or even a skeletal muscle abnormality. It has actually turned out to be useful for some patients to distinguish the etiology for their symptoms. Next slide, please. So once we've hopefully narrowed down what might be the pathology for the patients, what do we have to offer? Mostly what we have to offer in the PACS patients with cardiac abnormalities is what we've been offering patients even before COVID-19. So for patients with clear pericarditis, colchicine has been shown to be very effective at reducing both symptoms and the natural history of the disorder. If colchicine is not effective at relieving symptoms, then NSAIDs can be added, but we use them with caution just because they're rough on the stomach and can cause GI bleeding. For heart failure, we use what we know works really well, or what we call guideline-based medical therapy of beta blockers, ACEs or ARBs, spironolactone, and/or SGLT2 inhibitors. For the arrhythmia, it really depends on what the rhythm disorder is and appropriate therapy there. For POTS, patients with POTS, if we've confirmed it, this can be a frustrating problem to manage, but actually with a lot of coaching and reassurance, I think patients can see progress. I have many patients that have this, and what we prescribe are compression stockings, which these are actual therapeutic compression stockings with at least 25 millimeters of mercury pressure on them, and I always advise thigh high if possible. So they do help avoid some because they force the venous return to the heart to help prevent some of the tachycardia. Lifestyle, which means avoiding caffeine, alcohol, staying hydrated. And for the few that these measures don't work, we've used ifrabidine and beta blockers with some success to help control their symptoms. The other thing that's been shown to be helpful for POTS in many patients with COVID that just have poor exercise tolerance is recumbent exercise. And I want to emphasize the recumbent part of this. There seems to be something difficult about upright exercise for people who are suffering from worsened exercise capacity after exercise. And similar to those with POTS, they just don't seem to be able to fill the ventricle as well as they should. So they have poor exercise tolerance. But if they're exercising either on a recumbent bicycle or a rowing machine or swimming, the return from the legs of the venous flow is better, and they seem to do it, tolerate it better. And what we advise is starting slow and low. Go with just 10 minutes a day at a low level and keep working your way up to 5 minutes more per week, and then make it up to 30 minutes a day if you can. And with many patients, I've seen a slow but sure progress, and they seem to say this is working, and then they can expand to non-recumbent exercise after that. But just remind them this is going to be a slow and gradual process, that it won't get better overnight. It takes a while. I think one of the most important things we can do is just support the patient. I think we can always offer reassurance. Reassure patients that the death and advanced heart disease are very, very rare. And so as we all know, the pandemic has been very emotional and frightening. And so when people have heard that they might have a cardiac manifestation of the disease, it's frightening, and understandably so. But I think we need to put it in context for our patients and reassure them that this is something that is going to be likely manageable and not going to be life-threatening. The deaths from this are extremely rare. We don't really have great data, but it seems like it's overall well tolerated. And I think also confirming to people their symptoms are real, just like the study from Holland showed. Yep, there are people who are having symptoms that they did not have before their infection, and it's more so than their controls. But we also reassure them that it's going to take time, and the options above, depending on what their abnormalities are, should show improvement. And so just offer reassurance that this is going to take time, but it's not necessarily a death sentence. And I also reassure people that there are multiple studies currently underway to look at these specific issues and try to find the optimal therapy. I think last time I counted over 120 trials are underway to look at ways to manage long COVID with cardiovascular symptoms. So there's a lot of good data that will be coming available to us in the future. But until then, let's not forget first do no harm, because we don't want to necessarily initiate treatments that could cause harm for our patients as they recover from this illness. And I think my last slide is some take-home points. So things I'd like everybody to remember is that there are multiple potential mechanisms: thrombosis, endothelial damage, inflammation, recurrent infection that could manifest these cardiovascular disease post-infection. And in PACS, the symptoms of dyspnea, chest pain are really the predominant ones, but also palpitations. And they're present in somewhere around 20% of patients, depending on which study you use. I'm kind of going on the 5% data, but that's a lot when considered how many people have had the infection. It's also, as an aside, important to consider, is there a coincident cardiac disease that was present even before the COVID infection? And I think it's been called collateral damage. But when confronted with somebody with chest pain and shortness of breath, we shouldn't forget that before COVID, they might have had some disorder that's now manifesting. So we should always keep in mind that just because there was an infection doesn't mean there's no other cardiac pathology at play. When non-COVID related disease is excluded and you feel confident about that, I tend to offer reassurance, some rehabilitation, and there's also been some work with using cognitive behavioral therapy as a way to help manage this syndrome. And just reassure us that we have some really good ongoing studies now with different pharmacological therapies, perhaps cardiac rehab, that are underway that may offer a lot of hope in the future. That's all I have. So happy to take any questions or points.
Thank you so much. Before I dive into questions, I just want to thank Erica for that incredibly touching intro. I'm glad I didn't have to talk after that, because as someone who cries at commercials, I was definitely tearing up myself. But I think it just highlights, often our intros are really about our academic chops or what our titles are, and the work that we all do as healthcare providers is so incredibly important. And so, Erica, thank you so much for giving it that human touch, and Dawn for doing that important work, as so many of the people on this call do. So I do have a number of questions, and Dawn, just to start out, I didn't see, and maybe I missed it, but do we have much evidence around the different cardiovascular sequelae in different ethnicities or socioeconomic groups? We know that COVID has had a lot of unequitable effects, so I just wonder what that looks like in the cardiovascular manifestations.
Yeah, so I'm not familiar with the ethnicity part, except that I do know that you're absolutely right that the certain ethnic groups have certainly been much more adversely affected by the COVID pandemic in many ways. But in terms of how it manifests, whether it shows up as myocarditis versus pericarditis versus other groups, I'm not aware of any good data on that issue. So I would have to say that in general, we do know that people of lower socioeconomic status have been more adversely affected. And the reason I think this is also partly compounded, and we talk about this in cardiology a lot, is at the beginning of the pandemic, we knew that we had many patients out there who had cardiovascular diseases that weren't coming to see their doctors for fear of, I don't want to be in a hospital and get COVID. I don't even want to be in the clinic. I don't want to even bring on my symptoms. So I do know that we saw a sudden rise in people presenting with manifestations of their cardiac disease within a year or so. So in other words, I think the presentations were pushed down a year. And so I think what's hard to know is how much of that was attributable to fear of the health system and inability to access the health system. Even if perhaps some people wanted to come in, there were cardiac rehabilitations were closed. There were stress labs that were closed. So we might not even been pursuing heart disease as much as we should. So yes, there was certainly harm caused for those with heart disease, but how much is attributable to COVID? I don't know. I don't know if that's a really great question. I don't know how we'll know.
Yeah. Well, just to follow up that a little bit, I'd love to hear your thoughts on, I have a sense, and I've read some data, you probably know it much more than I do, about some implicit bias in general pre-COVID in the treatment diagnosis of some cardiac disease. If I remember right, there's underdiagnosis of myocardial infarction in women and African Americans. And so I wonder if there's a way to help providers make sure that they don't miss cardiovascular manifestations of long COVID in populations that they may have some implicit biases.
Yeah, that's a great point, and that's a really important point. That's actually why I presented as one of my first slides the data from the Netherlands, because I think that implicit bias would lead an individual to say, well, this person in front of me has got shortness of breath, chest pain. Well, a lot of people have that, so I'm going to, and I don't want us to do that. I don't think we should dismiss it. Now, should we necessarily be alarmed and panic? No, but should we take it seriously? Said, yes, I do hear you that you've got these symptoms. They probably are related to this. I mean, now we have some data that it's with as best you can, a control group, that the symptoms are more common, and I think we should feel empowered to say, I hear you, regardless of my implicit bias, I'm going to pursue these symptoms, because I mean, we all have that potential for dismissing concerns, and I don't think we should. I think we should take them seriously. Again, reassuring people that maybe it's not as severe as it sounds because it's scary, but on the other hand, to try to be empowered to say, yeah, there's perhaps 5% of people post-COVID are going to have some cardiovascular symptoms. And doctors, as you know, are people who we love to come up with a clear-cut answer and a clear-cut solution. So if somebody's in front of me with a ST elevation MI, I know exactly what to do, and I feel clear in my mind about what the right thing to do is. If somebody comes to me with probable endothelial dysfunction, maybe some microthrombosis causing symptoms, I don't know what the right thing to do is. So I think we tend to hide from that. I don't think we should. I think we should say, yep, I think it's there, it's real, and all I can do is reassure you that the things we talked about, we're going to try that with you and try to work through this and hopefully have some better answers. Now, on the flip side, we love to do things, so I don't think we should say, here, try taking an anticoagulant for 6 months, see if it helps you, because I heard there's more clot, because we also have the potential to do harm. So that's what's so frustrating for us caregivers, is we can recognize there's a problem, we want to do something about it, but sometimes it's without a clear answer, we don't pursue it, and we should. So I reassure them. I say, yeah, I think you're right. You've got the symptoms, and of course they want to get better right away. And many patients, I understand that, but I don't have a good answer. And as I also said, it was frustrating. Sometimes symptoms actually worsen over time. So we all have this idea in our mind. I got sick. I'm supposed to get better. 6 weeks from now, I should be back to normal, right? And when that's not happening, that's frustrating. Understood.
Yeah. Yeah, thank you. It's not easy to navigate as a patient or as a provider, I think. So one question that a lot of the people who were listening here have is about how reversible these cardiac manifestations are. Are there long-term effects on the myocardial tissue or the endovascular tissue itself? How long do we expect to be symptomatic? Sorry, my guess is that has, we don't have that answer yet, but yeah. just curious what, if anything, you would respond to that.
Well, I can answer it in two ways. So if we could extrapolate from what we've learned about viral myocarditis in the past, The vast majority of people do recover and do well. They might need to be on medications, they might need to be followed, but it's a small percentage of people that end up with severe cardiomyopathies and transplants and so forth. So that's rare. So if that's the case, or pericardial effusion, the natural history of that's usually very benign. And so we might have to do a TAP if it's hemodynamically significant, but usually colchicine works and most people recover. So if we can take what we've, I know that's a big stretch for COVID because it's all so new, but if we can take what we've learned from previous problems like this, we should predict that the vast majority would do well. The tricky one is what about the endothelial vascular injury, which admittedly we don't know what the natural history is well because we don't really have great tools for studying that. So, but again, with conservative measures, most people do well overall. But yeah, and I think I completely appreciate when patients ask me that very question. So how long is this going to take? I've gotten so good at saying, I don't know. In the last 2 years, I don't know, but let's just keep working together and see what we can do to get you better.
Yeah, that humility, we've all learned it for sure. One other question for you, Dawn, and then I'm going to pivot over to Erica for a few general questions, but and then we have plenty more to go if we have time. People are asking about the pediatric cardiac manifestations, and I know you're in an adult practice, but have you seen data on that? Are people seeing some of these things in pediatrics? Obviously, the post-vaccine myocarditis is happening, and especially teenage young men, but what else do we see in terms of post-infection cardiac stuff?
Yeah, I think the two most, and you're right, I don't know the pediatric literature as well as I should, but I think the two most significant things that have been seen are myocarditis, not necessarily vaccine related, but myocarditis. And again, that tends to be a slightly more serious manifestation than with the vaccine. But again, the vast majority have recovered. So I think even if there is COVID-related myocarditis, recovery is predicted in most kids. And then in the younger adults, I guess we'll call it, POTS has been one of the manifestations. And the other curious sidebar from POTS is a resting sinus tachycardia. So I'm working with one of my colleagues, Matt Dersenfeld, on this. We've seen a lot of people who have either inappropriate bradycardia for no clear reason and inappropriate sinus tachycardia, and it seems like everything else is normal. So there's probably some autonomic dysfunction, and they tend to be younger, I should say. So that's showing up a little bit. Again, that's not serious, but it's a curious finding that we've found, but that's what I've heard.
Great, thank you for that. Erica, let me just ask you, you showed us some of those really exciting collaborations between public health and academic on research and those kinds of things. Some listeners were curious about what we're going to do to fund some of the long-term research and services that are needed in the case of long COVID, and just don't know if you have any updates either at a state level or at a national level about what that's going to look like.
Yeah, it's another great question, and I think we're super excited. We got this sort of seed money to start that, and I think we're literally talking about this very thing, like how do we now re-up right away? Like, okay, and what about next year? And I think again, really grateful to be in a big state like this that has some opportunity to do that, as well as kind of work and advocate at the national level for. There are a lot of NIH sort of longitudinal studies that are happening as well that I didn't touch on. I think a huge concern, and Dawn alluded to this too, is just the number of people that are going to need sort of post-acute care for the various aspects of post-acute COVID and the healthcare services that I feel like we don't necessarily have an answer to yet. And I think all healthcare systems are going to need to really be thinking about and planning for that. Just as mentioned, the sheer numbers of people that we know or project are going to have long-term potential impacts. Not to mention all the indirect impacts, which is the other part that we're hoping CPR3 can really help with. I mean, we all know that mental health is just at all levels, right, is really stretched, and that's causing other kinds of medical morbidities too.
Yeah, interesting. Will be interesting to see, but hope that we can find a way to navigate this. So, the other question I always ask you to predict the future, and I'm not specifically going to ask you to do that so much, but a couple of points. One is, are there any variants of interest or concern on your radar that might make us think that to look out for another change in this exciting virus or a surge?
Yeah, so there's a couple other subvariants that we are keeping our eye on. One that was deemed kind of the Centaurus variant that's in India, and I'm already forgetting some of the numbers of the others we've been watching pretty closely. But interestingly enough, BA4, BA5 that are currently, probably over 90% of what we're seeing both here in California and nationally are really dominating still. And nothing else seems to be trying to compete that out, even though some of them in smaller kind of niches or in other parts of the globe have maybe had a higher R effective or look like they could compete out. BA4 or BA5 really is the one that's really dominating right now, and none of the other variants seem to be competing yet, including again globally. But we're watching closely and watching wastewater surveillance. I've gotten used also to saying, as you said, I don't know, and being asked all these questions a lot. But I think it was interesting. I think nationally they were looking at, okay, we know that winter is a respiratory virus season, and what could we see? So I think it's really hard to project though. And it is interesting just anecdotally hearing from pediatric colleagues about, RSV is already increasing again now. Like, I think our viral seasons are also kind of a little out of whack with this with the pandemic. And so the bottom line is I don't know, but we're trying to prepare for it and hoping that really it's going to continue to be mostly maybe very transmittable, but because of all the collective immunity, and especially if people go out and get their bivalent boosters, that we'll manage to not have another big surge. But we're all worried that we could have a surge.
Right. So quickly on that point of other respiratory viruses, this fall, as patients are coming in with respiratory symptoms during RSV and flu season, are there specific recommendations to test for both flu and COVID, to throw in other respiratory virus panels, or just use your clinical judgment and watch the EPI of those?
I think use your clinical judgment, but we know that they're both pretty non-specific, and then of course there's a lot of other viruses that we typically aren't able to test for, and RSV is pretty unusual to be testing for at an outpatient level. So thankfully, again, COVID tests are really easy to do, at least, at home and otherwise, and getting more and more affordable. So, but yeah, I don't think there's any specific new recommendations about that. The other thing just to mention, just because it's top of mind, is there was a recent CDC clinical alert about enterovirus D68. And so we may see some more severe acute respiratory illness in kids from that. And it can rarely, but can cause acute flaccid myelitis too. So that's something else that's on our radar for the winter here.
Right, and just specifically quickly to follow up on other exciting viruses, we're getting lots of news on polio out of New York. Any signals that might have moved across the country?
Yeah, I mean, again, thankfully, we have very high polio vaccination rates here in California. We're certainly, working and talking to local partners to make sure, are there any pockets of really under-vaccinated communities like what we saw in New York that we should be concerned about? But, we have over 96% of our kindergartners are up to date on their polio vaccine. And that, just to remind people, vaccines have prevented diseases. They've been one of the most important public health measures. And it is really unfortunate how much this pandemic has led to some vaccine hesitancy or decreased vaccine confidence. But I think this is a reminder to all that, vaccines have prevented things like polio. We are pretty confident here in California. We have extremely low risk, but we're certainly monitoring it closely. And I think that's the other reason I brought up the other enterovirus that is circulating, because it could be, it could look polio-like. And so we'll be, we're not yet looking in wastewater. I'm just going to go ahead and answer that question because everyone's asking. It's a much harder, apparently a much harder virus it's a different operational process compared to like Mpox and SARS-CoV-2. So we're working with academic partners and CDC to think about polio virus monitoring, but it's not as easy as, you can't just turn on a switch in the same way. So.
Right, okay, well, final question quickly. You talked about treatment. Any changes in the efficacy of Paxlovid and these days, or it's still working for the current viral strains, et cetera?
Yeah, no, it's still, I showed a couple of the more recent studies, and then the supplementary slides have a bunch of, more details on Paxlovid, but absolutely want to encourage people. And it's being underprescribed, I would just say. So I think that is why we keep bringing it up in these grand rounds. I really want to appeal to clinicians to really, and to patients to really be thinking about, ask about it, again, and like flu, if you treat it earlier, you're going to have more of an impact. So that's why we're rolling out these grants to get, workflows and processes to make it easier. I think we do still hear anecdotally patients having a hard time getting treatment, but it's absolutely reducing the impact, reducing hospitalizations, likely reducing deaths. So we want to continue to do that.
Yeah, great. Thank you for that. And unfortunately, we're out of time, but once again, I want to thank you both so much for being here, but also really for your incredibly evidence-based and scientific and thoughtful approach to these diseases, and the way that you both keep the humanity at the center of it. We would not be here without amazing clinicians and public health leaders like you. And then just to remind all the people on here, thank you for coming. Our next Grand Rounds is actually in October. We were maybe going to not do one, but I think October 11th, we still are going to do one, but watch your email for that and check at covidroundsca.org. And if you want CME, remember to fill in your survey. Thank you very much,
Thank
everyone.
you. Thanks.
Bye. Nice to see you, Don. Take care. Bye-bye.
Good seeing you. Bye-bye.
Bye.